All right. I'm Mike Sanderson. I'm a physician assistant. Graduated from OU in 2008, and this is Dr. Jeremy Woodson. He's kind of going to present the first part of the lectures, really the harder stuff, the stuff that we typically don't see a whole lot of, but there's orthopedic staff there that are really good at this stuff. And then at the end, we'll go through a bunch of fractures and show you some good websites and stuff that might be useful to you guys. So, Dr. Woodson, want to start?
So if you guys, first off, getting over a cold, so bear with me a little bit. If you have any questions, just ask. I think this is certainly for you. Mike, you chime in. A little dark?
Not too dark?
There we go. Mike can chime in on any things that you guys may see on your boards. I'll kind of try to hit some things that you probably need to know if you're working in the ER somewhere, you're working in primary care. I think those are probably important things for you guys to know. And going throughout all this, I think probably rule number one with orthopedics is if you're concerned about something, shoot an X-ray, okay? X-rays are cheap, they're really actually fairly low dose radiation. It's better than CT scans, it's cheaper than MRI, cheaper than even ultrasound. Get an X-ray, okay? So I'll probably hit that a lot, because that's a big frustration I think when people come in without X-rays. So there's objectives. I don't know if you guys get all that or not. I guess you're gonna get the lecture emailed to you.
Yeah, maybe I'm supposed to email it.
Oh, flip it up here. It's not flipping up there. Do you guys flip it? No. There we go. Okay. I think they're gonna email you this slide. I didn't make this slide. I'm kind of going off of what they want me to show you guys. So I'll kind of try to hit some points on here as well. But you guys, I'm sure, already know this stuff. History. How to take good history. Ask lots of questions. Can't go wrong with asking questions. Okay. So you guys, I'm sure, know that. Thanks for orthopedics in particular. A lot of stuff you're gonna pick up as they walk in the room, or parents can tell you first thing. They hurt. They limp. They fell. Something hit them, etc. I think the biggest thing for pediatrics, what we're doing today, is they're not adults. They can't communicate very well to you. So you have to be a little bit more aggressive at kind of pinpointing what's going on. And a lot of the times with pediatrics as opposed to adults is you'll see referred pain. The big example, and one that I think we're going to talk about this more, but I hope you take away today, is if a kid shows up with knee pain, sure, work up the knee pain, but also look at the hip, okay? That's probably the biggest thing, because there are a few scary things that can happen in the hip that come in presenting as knee pain that you don't want to miss, and they're really important not to miss and get on, from an orthopedic standpoint, pretty quickly, okay? So, ask, where's the pain hurting, or where does it hurt, but also look how keep your antennas up for it coming from somewhere. Developmental history is also important, and we'll talk about that a little bit too. Do they have any problems with birth? Were they breech? Do they have any hip problems growing up, etc.? Okay, endocrine problems, also good to ask too. Again, a lot of the times with physical exam, you're going to see them walking in. Parents are going to be holding them. One, especially with the lower extremity, which I think most of the talk is their lower extremity. The position they hold their leg in. That will tell you a lot. We'll get to that in just a second, okay? And examine the spine, all right? Look for swelling, look for asymmetry, stuff like that, okay? I'm going to tell you too, one thing this PowerPoint talked about is leg lengths, okay? Honestly, forget about that. And that may be probably not what Dr. McKim wants me to say, but leg lengths are really hard to judge just by looking on your own. I can change leg lengths by just which way you move the pelvis, all right? I don't do leg lengths that way. I do leg lengths on radiographs, by measuring x-rays, all right? So it drives me absolutely crazy when somebody calls me and says, the leg's shorter than the other. No, it's not. I can promise you it's not. So don't worry about that. That's really hard to do. So look at, and there's other things we'll talk about, okay? Put your hands on the patient. You guys know this too. You guys have done all this, right? History, physical, all that stuff, right? So you guys know this. Again, measure lengths, forget about that. Let's check the joints, look for swelling, look for deformity in particular. The nice thing about what I do is a lot of times you can tell if it's broken, okay? So, especially if you haven't done anything yet. All right, so again, kind of what I said to start the talk, x-ray. Don't be afraid to get an x-ray, okay? It's cheap, It really does not involve that much radiation, okay? Certainly not the radiation that you're gonna get with the CT scan. MRIs, bone scans, ultrasounds are much more expensive. That $600 for an MRI, that's a cheap MRI, to be honest with you. That's a bad open MRI that I can't even read, okay? So usually a good MRI is more than that, all right? So it's expensive, so think about that when you're ordering stuff. X-rays are cheap. A lot of times, especially with most of the stuff actually we're gonna talk about today, you don't need an MRI, okay? So get an X-ray first, all right? And also, on a side note, if you're out in private practice and you're taking care of adults, I know we're not doing peds today, but if you're taking care of adults, do not get an MRI for arthritis, okay? You don't need it, all right? Just store that away in the back of your head, okay? It's a waste of money. I never look at them. People still come with them. All you need is X-rays, okay? Labs, we'll talk about some of the, when you get some of these labs here in a second, kind of a good situation, but, you know, again, looking for infection and looking for things out of the ordinary, okay? So, some terms, I think I want you guys to understand an antalgic gait, all right? You guys haven't talked about that yet? I'm sure you have. So again, exactly, you guys know this. So it's when you spend less time on the involved extremity. So broken foot, infected joint on the lower extremity, they're just not on that foot, okay? The circumduction gait, when they swing their leg outward and forward, okay? They're kind of having to really give it help, all right? You see that sometimes. The equinus gait, that can be normal, okay? Or at the very least, something that can be worked out without surgery, but look for that too. People, if kids are on their toes, all right? They're toe walkers. A lot of times, again, that will go away as they kind of develop. So, and then a Trendelenburg gait. All right, you guys understand what a Trendelenburg gait is. I think that's an important one to look at. Okay, maybe not so much in kids. You probably don't see it as much in kids, but it's important to understand the anatomy and the biomechanics behind that. That the hip abductors are responsible for keeping your pelvis level when you're in a single leg stance of gait. Okay, or when you're in a single leg stance in general. I check this all the time. If somebody has a weak abductor, they're going to fall because that muscle's not holding their pelvis level. So to compensate, they got to go over. Does that make sense? And all it is getting your center of gravity and your weight over the extremity. All right. So you'll see people walk. They have weak abductors. They'll go like this. Okay. That's a Trendelenburg gait. All right, because they're having to shift their body over to help out their abductor muscles. Okay. So that's what that is, all right? And same thing, if you have somebody do a single leg stance, they'll fall. So correct, they go like this, okay? So again, toe walking, very, very common. You see this a lot, people get freaked out, parents get freaked out. It can be normal, and at the very least it can be normal. At the most of the time you can get it there without having to do any kind of surgery, okay? You can do physical therapy, do something like that. It's the kids that probably have CP, cerebral palsy, actually have something that the ones you may need to go do a little hip cord lengthening. But even then, send them to the orthopedist, they'll probably start with casting and serial casting, so they didn't get in there, so, okay? Bow legs, another thing, very, very normal. My wife's pediatric ENT, okay? She did all this too when we were in med school, completely forgot it. 6-month-old kid's bow-legged, she's freaked out right now. It's fine, okay? It's normal, all right? Normal to about 2 or 3, okay? And then it actually will correct and go the other way, go knock-knee, okay? And if anything, they actually get really knock-kneed, all right? Then parents start freaking about that too. They're too knock-kneed, they're walking knock-kneed, it's scary, okay? Again, normal, all right? And then as we get into a normal, or excuse me, as kids get out of that 8, 19-year age, they get to that adult alignment where we're all a little bit knock-kneed, okay? So as you guys are, if you're working with adults, that's normal. That's something to look for with arthritis. Again, I know we're not talking about kids here, but with arthritis, classic arthritis is people actually go the other way, back to bow-legged, okay? That's also a sign they're getting arthritis. So, but anyways, for kids, again, for the first 2 years of life, naturally bow-legged, usually corrects by 2 to 6 years to knock-kneed or valgus, okay? And then straightens up to more of a natural valgus alignment, all right? There are kids, there are some diseases that you don't need to know about. They still stay bow-legged, and even in 6 especially, yeah, then your pediatric orthopedist needs to know. That's called something called Blount's disease. Past what you need to know now, but that's worth looking at. All right, any questions so far? I know I talk a little fast too. So these next diseases, these next problems we're gonna kind of go through, there's a lot of info on these slides. I can't imagine you need to know all this. I think just some things to be aware of and keep them back in mind, because you will see, especially if you're working in ER out in a rural community somewhere, okay? So this first one is called a slip capital femoral epiphysis, all right, or skipping. You're gonna hear the word skipping. Anybody familiar with that yet?
Yeah.
Okay. You guys been taught in school?
Mm-hmm.
Cool. So I won't spend a lot of time with this then. Biggest thing from an orthopedic standpoint, as you guys know then, people are gonna come in with hip pain, or kids are gonna come in with hip pain, and they're gonna complain about their knee. Okay? Anybody know why? Without looking up there, I don't know if they're not. Why is that referred pain to the knee? Obturated nerve. Okay, you guys done anatomy. I know Dr. McNeil's big on anatomy. The anatomy, that obturated nerve goes right by that hip joint, all right, and goes down the inside of the knee, okay? Even adults, you'll see that with adults too, okay? But in kids, I think that's probably the biggest thing that you take away. X-rays on everybody. Kids come in with knee pain, sure look at their knee, but also look at their hip, okay? That's just things you can't miss, especially with this one. You don't want to miss this, okay? This is a big, big deal if you do, all right? So more commonly affects the left hip, okay? You see this in obese children, all right? Everybody understand what the proximal femoral epiphysis is? You don't understand what epiphysis is, right? Growth plate. So, and I think there's a picture, let's skip through. There you go, right there, okay? So that growth plate, it slides, all right? And you can see that on that x-ray there, okay? And that's a big deal, okay? So, see it in obese children, kids that have thyroid problems, endocrine problems. That's more commonly on the left, and definitely more males. I can't recall ever pinning a female's hip in residency, honestly. Usually it's a big male, okay? So keep just, again, knowing most common things, you know, so, all right. So again, medial knee pain, that's the biggest thing. Look at the hip, they come in. Ask time frame. Time frame is important, okay? If you get an x-ray and you see this, okay, well, how long has it been bugging the kid? And are they able to walk? Those are probably the next two big things that you're gonna call. Again, if you're working in a rural ER, you're gonna call Children's Hospital. That doc's gonna say, well, are they walking on it? And how long's it been going on, okay? Because, and we'll get to the classification in a second, but it drastically can predict how well this hip's going to do. Okay, is there going to be blood supply injury, and is there going to be bone loss, or are they going to be just fine? Okay, so it's very important two things to ask. Okay, forget about the leg length. Yes, the leg length, the limb is probably shorter. You can't reliably tell that on exam. All right, I just don't think that's accurate. So okay. Where their hip sits. You guys know this too. Their hip tends to sit externally rotated and flex. That's a position for a lot of hip things, okay? With hip infection, just hip inflammation, skiffy, Perthes, some of these things, their hip wants to go like this, okay? Because that's the easiest position for the hip to be in without having much pain, okay? Well, all right. So this is the classifications. You guys know this yet? Not really? Okay. So this is what, when you call somebody, this is what they're going to want to know, and this is why, all right? Again, is it stable or unstable, okay? And by that, can they put any weight on it? Even with crutches, even with a walker, even with something, can they put weight on it? If they can, it's stable, all right? And then the next question is onset. How long did it go to the start, all right? So those are the two things. When you call the Children's Hospital to pass this kid on from, Watonga, they're going to ask, okay? And so that's important because a stable hip, meaning with a kid that can put weight on it, has a lot less, or a decreased chance of getting avascular necrosis or blood supply, or the blood supply injury to the femoral head, all right? So when and I fortunately don't see this a whole lot anymore because they all go to Children's Hospital, but when I was a resident, that's one thing you have to tell the parents before you take them back to surgery. Hey, this kid's going to have a high risk of the ball dying to his hip, okay? So it's important, all right? As opposed to an unstable hip, okay? An unstable hip is very, very bad prognosis. They can't put any weight on it at all. A lot of times we would take those to the OR in the middle of the night, okay? So that's a bad deal, all right? And I think it's, I don't remember what the percentage of those that die, let's see what's in here, it's 90, 95%, something like that, pretty high. Let's see it in there.
I don't think it's in the slide.
Not the
It
slide.
is.
It's rated at 90%, I don't remember off the top of my head, because I haven't taken orthopedic boards in a while either, but it's higher than 90%, okay? So it's a very high risk of blood supply damage to the head, okay? And then again, chronic versus acute on chronic, all right? So sometimes they'll be coming in and parents say, yeah, it's been bothering them for a month, but the past week it's gotten worse, okay? So that's acute on chronic. X-rays, so you definitely want to get AP X-rays, and the best thing you can do is draw this line like this here, okay? Along the femoral neck, and see if it touches, if it's touching at all. Is there a pointer on here? Ooh.
What did you do?
There we go.
There you go.
There's a stick on the.
Oh, okay. Basically, when you draw this line, you want to see, yeah, I'm not too short for this, guys. You want to see it touch the slip epiphysis, okay? If it's not touching it at all, like that's a very dramatic one, then it's slipped. But you'll have, that one's obviously obvious, they're not always that obvious, so sometimes they're very subtle. I agree with this last slide. Frog legs are tough, I wouldn't push the kid. You can, usually you're gonna be sitting like this anyways. If you can get an x-ray with the leg like that, that's fine. Don't force it, don't force it, that's gonna make things worse, okay?
Go back one slide real quick to the x-ray again. For board purposes, just how it's describing, following the ice cream cone or the, off the cone or whatever, you'll see that on the boards. You'll probably see that on the McNeil test. So if you see that, just a key word for you guys, so you'll get the question correct. I think on my research, I saw this, so just put that in the back of your mind. So.
Ice cream ball cone.
Yeah.
I can't, and he's right. I think in practice, they're not always as obvious. I bet on the boards they're be as obvious, don't you think?
That x-ray, I think that's very similar to the x-ray I had. So it was actually on my boards and then my research, I had this exact question. So as far as the ice cream cone,
Always get, just to get an AP pelvis, that's probably a good way to compare. If it's a subtle slip, you can compare the other side, okay? Labs aren't necessary, at least before you send them. I wouldn't certainly necessarily need to get labs, but you may find some endocrine stuff down the road that it would be worth getting to an endocrinologist, all right? So we see that picture, memorize that picture. Again, the big complication is avascular necrosis, okay? That's bad in a 7, 8-year-old, that means when adults get it, they get hip replacements, all right? You can't do a hip replacement in 7, 8-year-olds, so not a good problem to have, all right? That's why we get to it quick. Some guys will reduce it and fix it, put screws in, 1 or 2 screws in, okay? Just like that. So I think probably highlights for that, know what it looks like, know the classification, know how they present. Short, external rotated, can't walk, okay? I think those are probably the 3 big things that you need to know. All right. Questions on that? You guys are easy. Developmental dysplasia of the hip. You guys done this already? Not really?
I don't think so.
Okay. So this kids can be born without their hip in the socket. All right. That's what's called developmental dysplasia of the hip. If you guys go to your peds rotation, you'll see them doing the exam on babies, where they're trying to dislocate the hip and move the hip around. All right. It's important because it's something that's picked up early enough, can be treated, and they can go on to develop a completely normal hip. All right. The problem is when the ball is not in the socket doesn't develop the way it should, neither does the ball. Okay, femoral head and acetabulum. All right. I'm talking to patients on these ball and socket things, so you guys know the terms. Okay. So if the femoral head is well seated in acetabulum and it's allowed to sit there, the acetabulum develops around the femoral head the way it's supposed to. All right. So that's why everything aimed at treatment is early pickup and early treatment, and it's not a problem. It's the ones that are missed where it's a problem. And I think one thing this website, or this PowerPoint talked about was sometimes it's picked up in a year. This should be picked up well before then, okay? This is also one where if you have any kind of suspicion get an ultrasound, okay? So, goes in this x-ray. X-rays are tough. There are some things that my partners who do pediatrics look at on x-rays, but diagnose it, you can't diagnose with an ultrasound. And if you're any suspicion at all on exam, obviously your exam should be first. If there's any suspicion at all on exam, get an ultrasound, okay? That's how you find it, okay? So things about developmental dysplasia of the hip, it's left hip more common, females are more common, broach, a baby that's in the breech position are more common as well, okay? So there's a risk factor again, Native Americans. Oh yeah, parents, important to ask mom or dad if they had any history of hip problems, okay? That's also a big one too, all right? Firstborn child, I don't really know why. Again, I think that's still, that's one thing to know too. Breech position, cerebral palsy patients, you can see that as well. That's more of a, so this is there are some things in orthopedics that we consider packaging problems, meaning they're kind of squeezed in mom's uterus, and this is one of those, okay? Cerebral palsy, on the other hand, is more of a neuromuscular problem, where their muscles aren't strong enough to hold that hip in the socket, okay? While needing to develop. So you see this a lot in cerebral palsy kids, and that's more of a muscular imbalance, spasticity thing, okay? Being swaddled often, they talk about not swaddling the babies a ton with their legs crossed like this, okay? And a lot of the things that you see, we had one for our 6-month-old, there's a strap that goes between their legs, kind of forces their legs out just a bit, okay? Because that's the position that we're going to put the hip in to get us in, all right? So those are risk factors. I think the big thing again, breech position, firstborn, female, and in a genetic history, parents that have it are important. Slow down, because I know I'm talking fast here. So this says shortening, what did it say? Altered gait is the first sign, it's too late. I shouldn't say it's too late. It's more difficult, okay? This is why every pediatrician you're going to see on that 4-month visit, they're going to check her hip. They're going to hit her hip, okay? And even earlier, it's early on. They're checking hips, they're making sure the hips are stable, they're sitting in the socket, because early recognition, again, is easy to treat, all right? The moves that you'll need to know are the Barlow and Ortolani, and we'll show those in just a second, okay? Again, ultrasound. Ultrasound are good to use if you have any suspicion at all, okay? Not an x-ray, I'd go ahead and get an ultrasound. So you guys heard these terms, Barlow and Ortolani? Okay, you're pediatrics, so you know the Barlow is the clunk out, Ortolani is the clunk in, all right? So there are two separate exams that you describe as positive or negative, okay? All right. Sometimes they go out, they don't always go back in, all right? So you guys done these, tried these on models or anything like that yet? Okay. It's kind of a unusual thing to feel when first time you feel it. It's not hurting the baby at all, okay? So don't worry about hurting the baby. But I would encourage you to try it when you're on your pediatric rotations. Every baby that comes through, give it a shot. Give it a shot, okay? I think it's good. It's a good exam, a good thing to know. Again, because if you catch it early, it's easily treated. All right, so it's one of those that everybody should know how to do if you work in primary care or orthopedics. Okay. Is this video? Huh.
It doesn't work.
It didn't work. Okay. Google it. There's one on there, sure. So again, X-ray. That X-ray is too late. Okay. See how that X-ray up there? See how the femoral head looks flattened? Obviously, it's not in the socket. Even the socket, if you look at that socket or the acetabulum critical, it's not a normal acetabulum. It's not a normal rounded acetabulum with a good walls to it. Okay, as opposed to the right side. So that one's too late. And again, this is why that's a big surgery right there, guys. And that acetabulum, that's way too late. Actually, that acetabulum's already closed. Growth plate's already closed on that one. That's probably if it's a girl, 12-year-old, it's a boy, 15-year-old. So that's way too late there. So that's a big open deal. They're making osteotomies. Not good, okay, not good. So you don't want to get that far along in x-rays. Again, any suspicion at all, get the ultrasound, all right? That's one where I'd rather have normal ultrasounds that really didn't have it versus miss one, okay? So, big thing, all right? This is what you do to treat it. Anybody ever seen a Pavlik harness? No, so that's that bottom right there, that baby is a Pavlik harness. So see how it's got the hips rotated in the socket, okay? I would tell you, don't do this in your practice unless you're in orthopedics, okay? And I wouldn't treat this, to be honest with you. I would treat this as a pediatrician. Because you don't want to leave the babies in that forever either, because you can go back to the same problem where you can get avascular necrosis, all right? So I don't even remember what it is now, to be honest with you. There's a regimen that you do with Pavlik harnesses. You don't just throw it in and leave it in for a year and say you're good, okay? So be careful about treating it, but that's what you do. So if you see kids like this in pediatrics, they come in wearing Pavlik harness, that's what it's for, okay? So that's the treatment. Early on, later on, it's more aggressive stuff, okay? Questions about that? Probably need to know the exams. I think those are on every board I ever took, even in med school, okay? Because again, it's something that's important to know. And then risk factors. I think that's probably testable stuff. All right, Lead-Calf-Perthes disease, or what most guys just say Perthes, okay? This is where they actually get avascular necrosis of the femoral head, or AVN. If you hear AVN, that's what they're talking about, okay? This is idiopathic. We have in adults, you can see if they dislocate their hip. You can see in adults that are HIV or alcoholics, get lots of steroids. In kids, a lot of times we don't know, okay? It's a lot of times idiopathic, okay? Usually you're going to see it 3 to 12 years of age. Around 7, 8, I think is kind of the age usually you're going to see this, okay? And a lot of times this is unilateral. It's one side, all right? Same thing. They're becoming in hip pain. This is not so much of a they can't walk on it, as much as it's just kind of been hurt, all right? So we don't know. There's some thought that some of these kids actually have a coagulable disease, but a lot of times you can get blood studies and they're fine, they're normal, all right? So, but what happens is the blood supply gets interrupted, it gets damaged, the bones die, they infarct, all right? And then, given enough time in treatment, you give the femoral head time to revascularize, it will usually revascularize, okay? If you guys are in, again, a pediatric office and they're seeing orthopedics and they're scared and they're afraid and they're wondering how bad is this, well then you can tell them, if their kid's on the younger side of things, 7 or 8, as opposed to an older kid, it's better for them, all right? Kids have, and this is going to be the case when Mike talks too, kids have an unbelievable ability to remodel and repair before you get to be adults, okay? So the younger they are, the better off they are, all right? Males more than females too. So again, they're limping. They will sometimes complain about pain, but sometimes it will be painless. And if there is pain, again, groin pain's also, I didn't really mention that. You see that more in adults. They talk about groin pain. That's usually actually hip. A lot of times adults come in and say, my heart over here, that's not their hip, okay? Groin is hip. This is more something else, okay? Bursitis or something else, all right? So kids, same thing. You'll be talking about groin pain, proximal thigh pain, or the knee pain, all right? So just keep an eye out. Again, keep the antennas up if you do knee pain in kids. That's the biggest complaint. Most of it's the parents come in and say the kid's been limping, and they don't know why. If you look at their range of motion, they are going to have limited internal rotation and flexion, okay? They're these obligate external rotators, meaning as you flex them up, their knee tends to go out, all right? Because it has to accommodate for that head position, okay? So that's something to kind of keep an eye out as well. And again, to get x-rays, a lot of times you'll find this, all right? Okay. Roll test. I don't know if I know what that is. Patiently. So it's putting their hip in rotation, again, trying to rotate their hip. So the roll test, I don't know if that's something you'll be testing on or not, to be honest with you.
I don't think I've ever seen that.
Yeah, that's a new one to me. So, but basically, again, you want to check the range of motion of the hip. All right, I think a good exam, a good musculoskeletal exam is range of motion, swelling, deformity, pain. Okay, so you want to check range of motion. All right. X-rays, a lot of times you see these on X-rays. So you guys see right there what these look like. So that one on the left there is a normal hip. Believe it or not, even though it looks a little abnormal. All right. The one on the right, see the difference. See how that top part of the femoral head or that epiphysis is flattened. Okay, as opposed to kind of a nice round contour there. It's flattened, it's getting what's called sclerosis, or kind of a whitening of the bone. The growth plate looks abnormal. And so a lot of times the x-rays will show this. What the orthopedics may even do is use an x-ray with dye too, to really highlight the femoral head, okay? Labs, you can have a slightly elevated labs. I don't really recall you actually really checking a whole lot of labs on this, because this is, again, most of this is idiopathic, all right? So the treatment, there's a lot of treatments, both surgical and non-surgical. Honestly, this is probably more than even this slide really indicates, because there's a lot of classifications that you got to know, other than just that sometimes we can treat it without surgery, especially if it's early on in the young patient. If it's further along and really bad AVN and an older patient, then sometimes you need to do a surgical procedure to get that head sitting in the socket there, okay? So again, I think the biggest thing for you guys, if you're telling the families what to be aware of, younger age of onset, the better they are going to be. All right? Questions on that? Okay. Osgood Slaughters, everybody heard of this? Okay. This is a common one. It is strain at the tibial tubercle with a patella tendon insertion, all right? The kids are growing, there's more than this too. You can have strain at the Achilles insertion, or apophysitis, okay? Called Seaver's disease. Really those are probably the two big ones. There's two big tendons with two strong muscles attached, and you can get pain at the insertion site, okay? So you see this a lot in kids, especially kids, boys, girls playing volleyball, boys playing basketball, kind of that early teen years, you'll see this a lot, all right? And it really is an overuse syndrome. And on a side note, I think probably my soapbox right now, for you guys, if you're telling families, hey, tell them not to have their kids play one sport year-round, all right? There was an article in our journal the other day, it was a really good article that talked about kids that play one sport are more likely to get injured than kids that play multiple sports, all right? There's football coaches that won't even pull players, won't even recruit players if they're not playing their sports, all right? So it's a really big deal right now for kids that you guys need help too. When you get out, tell families there's going to be that urge to just play one sport. It's not good for the kids, all right? Same thing. This is what happens. You start seeing stuff like this, okay? So this is very much an overuse injury. And basically it is a microscopic fracture of the tibial tubercle, all right? So you guys know what the tibial tubercle is, right? With a patellar tendon insert on the tibia. That's a growth plate there, okay? You get microscopic fractures of that tubercle, which causes, and sometimes you can even have a fracture of that, which is a surgery, okay? But it causes the growth plate to kind of look abnormal, all right? It's more males than females, although again, I think in volleyball, girls playing volleyball has been a big deal right now. Those girls are playing year-round, all right? And we're seeing more of this in females too, so. Okay? So you can see, if you're just looking at it, look at that one, if we're looking at this gentleman right there, the right knee, you can see how he's got that increased fullness in his tibial tubercle. That's an older individual, but that's because that was a chronic thing for him, that he had probably Osgood Schlatters, developed this abnormal tibial tubercle, like you see there on the bottom of the x-ray, and it stayed like that, okay? So you start to see swelling in particular before it actually gets ossified. You'll see swelling in young kids over the tibial tubercle. They'll hurt over the tibial tubercle, okay? It could be both sides. I don't really call bilateral, unilateral, what's more often or not. This is often bilateral, but you can see it one side or the other. So, in the exam, yeah, again, I think x-rays are cheap. I'd get x-rays because you can see the growth plate, but this is pure an exam. So, okay? You don't need ultrasound for this one. You definitely don't need an MRI, anything like that. All right? Treatment is conservative. One thing they don't have on there, treatment is it needs to focus a lot on flexibility, okay? And not just quad flexibility or hamstring flexibility, but also Achilles flexibility, okay? If you have a tight Achilles and you have a plantar, equinus contracture, that puts a lot of increased stress on the front of your knee, all right? Also see it in adults too, okay? So flexibility is a big thing, all right? But then same thing, ice, you guys know this, rest, NSAIDs. Limited on the NSAIDs a little bit for kids. You don't want to, get them on that too much, but just ice in the knee. The pads can sometimes help. The brace, those little straps, sometimes help. But this is also one that, again, you kind of get them from playing the sport year-round, get them flexible, manage it until they get older, okay? Until their growth plate's close. All right. You don't need to mobilize them. I can't say I've ever done that, so I wouldn't do that. And they're really not surgical treatment for this either. Questions on that? You guys are easy. All right, transient synovitis, anybody know what this is? Okay, this is, looks like an infected hip, all right? It's basically a diagnostic exclusion, meaning you need to rule out an infection in the hip, but it's just inflammation, all right? It's inflammation of the hip joint, usually associated with an upper respiratory infection, or an illness of some sort, okay? So you're working in the kids' ER, you're working in a rural ER, they're gonna come in, their hip's gonna be in this shortened, or it's gonna be in this external rotated kind of flex position. They're gonna act sick, but what you'll kind of get to see the difference of a truly kid with infection and this one, they don't act as sick as those kids do. But you need to rule out infection, okay? Sometimes it can be associated with the trauma, all right, as well. And vaccines, when kids will get their vaccines, they can get to develop this as well, all right? But you gotta make sure, I think the biggest thing with this and infected hip, which we'll talk about in a little bit, you gotta make sure there's not an infection there, all right? So again, same signs as well, same signs and symptoms. They're not as septic. They don't really look that sick, but they don't look comfortable either. Usually the gait, that's something that's pretty common. They'll start walking in the morning, or sorry, they'll have pain in the morning, start walking throughout the end of the day, okay? But it's something, again, that I think if they're having fevers, they're having any evidence of infection, you gotta get fluid off their hip. And that's where you call the orthopedist, use an ultrasound, use an x-ray, or something to get the fluid off the hip. Or if you're in a big hospital, the radiologist can do it, and you take that fluid off, you look at it, okay? If the fluid looks cloudy, looks infected, that's surgery, okay? If it looks straw colored, doesn't look infected, it's anti-inflammatory, so let the thing resolve on its own, okay? So it's a big difference, obviously. So when I would get called a lot of times to the ER as a resident, if they didn't look sick, the labs were equivocal, although sometimes center rate and white count can be elevated too, okay? But if they weren't drastically elevated, then a lot of times we give them a dose of anti-inflammatories first, check them in a few hours and see if it got better, okay? If it got better, we treat it like this. If it didn't, then we go get aspirin, all right? But this is treating kind of conservatively versus an infected hip, which is this one, all right? This is more aggressive. This is surgery, okay? These kids look different, all right? They look sick. They act sick. They have high fevers. They have high white count. They have high CRP, etc. You guys know those terms, correct? So those things we look for to help us guide for infection, okay? If you have an infected joint of any kind in a kid and or an adult, it hurts to move the hip, okay? As opposed to the transient synovitis, where it'll hurt to move the hip in the morning, but a lot of times they will move it and get going as they get older, okay? As they get going throughout the day. This one doesn't change depending on the day, and it hurts to move the hip all the time, all right? This is a surgical emergency, okay? This is something I'd come in the middle of the night for to do, all right? So this is something you don't want to miss. So even if you think it's transient synovitis, better to be safe than sorry. Pull fluid off and no. Okay. So they hold that hip in that same position. They take a look for how they're holding the leg. Okay. You see it in kids around 2. All right. Anybody want to guess what the most common bacteria is? Staph. Staph. It's technically the most common bacteria you're going to grow. A lot of times it's actually unknown, okay? But it's usually staph, all right? So again, you look for those high white count, high inflammatory labs, the joint fluid looks infected. It a lot of times will grow something, especially if parents haven't given antibiotics yet, all right? X-ray is good to get, but it's not going to show you a whole lot. Again, but it's cheap, get an X-ray, be safe, okay? Because all these, you never know sometimes. Sometimes a skiffy kid can come in with shut throat, and you think he's have a septic hip, get an X-ray, look like a skiffy, okay? So always get X-rays. So staph again is the most common. You can have a bunch, okay? Gonorrhea is something you can get that you can see. I've seen that before. The H flu is something that you see. Not as much recently, but it's something you can be seeing as well, okay? The treatment. I want to be careful about that. It's never just antibiotics alone, okay? Treatment's never just antibiotics alone. This needs to be IND in OR, all right? And then put on antibiotics, okay? So never antibiotics alone. All right. Any questions on that? No, moving kind of fast. Nursemaid's elbow. You guys know what this is? Okay. Any questions on this? You guys hit with this pretty hard. You know the reduction maneuver to get it back in? We talked about that. So the basic underlying pathology, this is easy. This is one, honestly, I'd say I put 1 or 2 of these in. Usually never makes it to me, it stays in the ER, stays in the pediatrician's office. So you understand the underlying pathology. The radial head slips outside the annular ligament. You guys remember what that is, right? The ligament around the radial head, okay? And it slips out, all right? Usually because the arm is getting jerked with it pronated, okay? So they're all palm down. Remember those terms, pronate and supinate, okay? So the fix is to flex it up and put your finger on the radial head and push it back in, okay? All right, and that's the fix. And it scares the living daylights out of kids, and they usually are gonna hold their arm, give it 20 minutes or so, come back, and you'll find them moving their arm, okay? And I would probably kind of wait to see if they did that, all right? But this is very, very common. Again, but something I hardly ever see. Usually they make it out of the ER or the pediatrician's office, all right? Yeah, they come in holding their arm, their elbow flexed usually, and their big thing is their hands like this, okay? So it's pronated, all right? So usually their arms like this, okay? But they're usually not, that's the other thing, is as opposed to a fracture, they're usually not that uncomfortable. They're pushing in the arm, they're usually not screaming, they're usually not crying a whole lot, especially if it's not right after it happened, so, okay? Questions about that? Everybody understand how to get that back in? Some of you are gonna see. Oh, there's a good video picture right there. So again, flexing the hand, putting your finger on the radial head, you'll feel it pop. You'll feel it kind of snap in, okay? And then one thing I didn't mention, supinate too. Scoliosis. Lots of scoliosis. I think, I don't know how many slides this is, but there's a lot to do with scoliosis, and I'm just kind of hit the high points, things that you probably need to know, keep your antennas up for, okay? One thing when you're looking at these x-rays, by the way, if you've ever seen scoliosis x-rays, they're flipped. You know, normally you're looking at x-ray, you're looking straight on, all right? For scoliosis, we always flip them, all right? So on that x-ray, right's over here, left's over here, okay? So opposite of what you know we're looking at, all right? So there's a thoracic curve, okay? Although, I guess the x-ray is probably normal, actually. If you look at most orthopedics, x-rays are going to be flipped, okay? That x-ray, I guess, is probably normal. Usually the curves are on a right-sided curve, okay? Usually it's the thoracic lumbar area, or the thoracic as it transitions to the lumbar. You want to look for a right-sided curve. Things that are not a non-right-sided curve, you have a little bit more anxiety about, all right? But usually you see these 10 to 13 years old, okay? Is when they really kind of become prominent. Usually seen in girls, although we picked up one on a guy in physical last year, so, okay? Things to look for is their shoulder, and let's get ahead here real quick, we'll go back to that one. Their shoulder and their pelvis alignment, okay? And so the exam in clinic, you stand behind them, shirt needs to be off, and you have them bend forward, okay? Touch their toes, and look at that alignment of the spine. I used to have bosses that would draw little markers on their spine's processes and watch them, okay? And so you want to look at their shoulder level as they're standing, even with their shirt off, okay? Their shoulders are tilted, all right? Look at their shoulder blades, one more prominent than the other. And look at their pelvis height. And usually that requires, the best thing to do is put your hands on that crest, all right? And see how where your hands do, your hands will be tilted like this one way or the other, okay? So that's real important to look at and to know, along with a good neuromuscular exam. I know Dr. O'Donnell, you guys do that, right? Neuromuscular exam, 5 out of 5 strength, 4 out of 5 strength, checking upper motor neuron signs, checking reflexes. All very, 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 very important in this, okay? Because if there's any abnormality, we need to get an MRI first of the spine, okay? So very important to do a good exam on spine, or excuse me, on scoliosis, okay? And the spine in general, even the spine in general, okay? So again, you look for the asymmetry of their shoulders, the iliac crest, get a good neuro exam. The Adams test, or the forward bending, is where you have them bend down, touch the ground, okay? And then x-rays. Again, I don't know if you're going to need to measure Cobb angle or not. That's how we determine the degree of the curve, okay? If you're doing this, the x-rays need to be flipped again too. So again, that's probably a big thing. These x-rays are usually flipped front to back, okay? But what the cob angle is, I can't imagine actually they're gonna have you guys do that, but it may be worth looking at, is you take the, it's really hard to do, honestly, and I don't really enjoy doing it either. But you take the top of the curve and the bottom of the curve, okay? You draw a line from the top of the end plate or the top of the vertebral body on the top one and the bottom of the vertebral body on the bottom one, and you draw a right angle from there, and where those two angles intersect is your cob angle, okay? And that's what we use to measure how big is this growing, how much is their curve getting worse, etc. Not something that I can't imagine you're gonna have to do, honestly, unless you're in a spine office. But it is important at following the progression or lack of progression over a course of years, okay? The biggest thing I think for you guys, know the good exam, look for the asymmetry, and a good neuro exam. A good neuro exam will tell you a whole lot, all right? Because if there's any symptoms at all, get an MRI. So treatment on this, I would say number one, definitely get to the spine guy, okay? I personally would never treat this. Bracing, they talk about bracing, that's kind of questionable. It really probably depends on more in depth than what we're talking about here. What's causing the scoliosis, the idiopathic, is there a neuromuscular symptom? There's a lot more to that, and bracing is really, I can't say I've seen bracing help a whole lot, okay? There's some studies that are really looking at where it really does a lot, but that's something that people talk about doing in 24 degrees or so of the cob angle. Usually you watch it and you see if it progresses above 40 degrees, if it's idiopathic, if there's an underlying cause, even less than that sometimes, and they get a surgery to fuse this, okay? More to kind of get them lined up, all right? Big thing for you guys, again, know the exam, get a good neuro exam, and you pick up stuff. All right? Kind of these last few, we'll kind of go through pretty quick, so I'm probably going to run out of time here, but any questions so far on that last one? All right.
Let's get through arthritis, I'll take over, so I can,
Okay.
we'll take a break.
Okay. So JRA, or juvenile rheumatoid arthritis, and I guess it's been changed now to JIA. I think I still use JRA, but it's joint pain in kids, and I've seen this a few times. You come in, you've ruled out everything. You ruled out transient synovitis, you ruled out infected joint. Their labs don't look that crazy, and they have this pain in these joints that are swelling and moving. That's when you start seeing this JIA, okay? They usually do hurt. Yeah, they usually do hurt. I think most of the time there's some pain coming from somewhere. Again, it's a kid, sometimes they can refer to elsewhere in the body, but it usually does cause pain, okay? It really, again, they talk about right there, diagnosis exclusion. You rule out infection, you rule out transient synovitis, Lyme disease, one thing you guys can get. Have you guys been talking about Lyme disease yet? So that's common actually right now. I had somebody the other day got Lyme disease, and one of our patients did, right? Yeah. Had Lyme disease playing golf, okay? So things you gotta rule out first. And then if you rule everything out, you've aspirated it, then you go to rheumatoid labs, okay? There's kind of these three subtypes: oligoarthritis, polyarthritis, and then this is the whole systemic arthritis, okay? This oligoarticular JIA is the most common. You usually see this in younger kids for sure, and not a whole lot of joints. One joint, two joint. I had a little kid that was 4 that had one joint, you know, and we worked it up, and it was JIA, okay? So this is not as many hip, not as many joints. I'd say most common is the knee. Oh, that says that there, yeah. The knee is the most common side effect for sure, so, okay. So you get labs, you're gonna get these you guys heard about these labs that you're looking for rheumatoid. You get all those labs worked up. Sometimes they can be positive or negative. This is where the endocrinologist is really good at, so, okay. This one definitely has a good prognosis, although it's worth telling the patient and the patient's family, hey, this is autoimmune. You're going to see, you could potentially see other things, psoriasis, uveitis. Some of them are the HLA-B27 positive. You guys heard of that yet? So they can get GI stuff too. So they may see more autoimmune stuff. Okay. The polyarticular, 5 or more joints. All right. Usually you start seeing large and small joints. You can see it really, really young, or as they get a little older. All right. So this is definitely one of those. Again, you have your antennas up. This one's pretty obvious because there's swelling, pain, multiple places. Okay. And then the systemic onset. This is one it's seen with high fevers, and I've seen this where they get these fevers, these daily high spikes that kind of come down and high. You'll see 103, 104 come down. You can have with a rash, and then again, a lot of times, and this is true, the arthritis itself is actually kind of more later to find. Usually, the fever is kind of one of the earlier things to see. Okay. With this one though, there's a lot of other things going on. Like talk about there. Hepatosplenomegaly, so good physical exam of the abdomen is also will pick up things, okay? So treatment, anti-inflammatories and these DMARDs. You guys heard DMARDs yet? You'll hear lots about those, okay? Because they really are changing things. And again, honestly, there's more than just methotrexate at this point. There's so many of them out there now that are really making a big impact on these not just rheumatoid patients, but patients with Crohn's and ulcerative colitis and a lot of psoriasis, a lot of other these autoimmune stuff that these DMARDs are really making a world difference on. Okay, you can do corticosteroid injections too, especially if it's the JIA injections in the knee will help. I've even unfortunately gone to scopes the knees just to get everything out of there. That's helped too. Okay, so but usually a lot of times you can be treated without surgery, anti-inflammatories and such. All right. Now let's carry stuff. I'll let Mike take over.
Well, we take a